We'll get started. So thank you so much to everyone for coming. Today, we're really pleased to have Dr Joanna Hampton, who's a consultant at Addenbrooke Hospital in Cambridge, talking through ECG cases with us today. And she is the co-author of ECG Made Easy and has a wealth of expertise to share with us today, going through cases which will be relevant to work on the wards as well as, of course, exams. So I hope you all enjoy and find it helpful today. There's going to be quite a lot of interaction on polls and using the chat, so please do use those and let us know if there's any issues with those as we go along. I'm Ben, one of the final years in Cambridge and part of the MedStop team running this series on essential investigations. And we're grateful to UEA MedSoc for sharing their Zoom account with us today. And we should just say that we are recording this session. If anyone has any issues with that, please drop me a message on the chat that we're recording it, so that hopefully it can be of use to those who aren't able to be in the session today, but might find it useful down the line. So thank you very much again for being here. This will be running till just before 7 o'clock. Without further ado, I'll hand over to Dr. Hampton to start the session. Thank you very much, Dr. Hampton, for being with us.
Thanks, Ben. Thanks very much for asking me to come back. Can't have been that bad last time. I hope most of you who are here this evening were here a couple of weeks ago, where let me just get my talk up. So I went through the basics of how to interpret a ECG. And so what we're going to do tonight is I've picked 10 sort of common things that I think you ought to know about. It's quite difficult picking ECGs because there's just millions of them. And there's lots and lots of things we can talk about. So I absolutely haven't covered everything because it's impossible to. And it's quite difficult doing, this sort of thing over Zoom. So definitely use the chat. I've put lots of polls in. It can be quite difficult to ask polls on the whole ECG because there's lots to talk about. But I think it's really just a way of making sure you engage and have a go. I just want to remind you about the structure. So I'm not expecting anyone to be brilliant at ECGs. This is meant to be aimed at 4th and 5th year medical students, so not final year students, but just getting going. So what we talked about last time was an approach to interpreting the ECG. So thinking about this thing RRP, WQST, so rate, rhythm, P waves, width of QRS, are there Q waves, and ST segments and T waves. And then we did also briefly talk about axis and the whole thing about left for leaving and R for reaching. What I want you to try and do for each ECG is to get into the habit of reporting the findings of the ECG. I think this is really, really important. So you report what you see on the ECG, and then you interpret the ECG with regards to the patient. Because an ECG has two meanings, really. It can be normal or it might not be normal. So just get into the habit of always reporting an ECG with exactly the same structure. I've given you a suggested one there. It's not the only way by any means, but get into the habit of doing the same thing every time. Like I said last time, what you're really trying to do is just treat an ECG as a big pattern recognition exercise, and then you won't miss things. If you're faced with an ECG that looks horrible, don't panic. Just go back to the basics. What I would also suggest is that you either have your own laptop, have a phone open so you can just jot things down, or grab a pencil and paper so you force yourself to write down a report, because it can't all be done on Zoom, and I really want you to think about what can I actually see on this ECG. So we've got 10 cases. I'm not sure we're going to get through them all, but let's have a go. So here's the first one. This is, I can hardly see what my slides say because there's so much Zoom bits and bobs on here. So this is a 50-year-old man who had 18 hours of chest pain, and he presented to ED. So have a look at it and think about the RRP WQST. And we're going to, the other difficulty is, of course, of leaving this up while you're doing the polling. So have a good look. And the first poll is, what is the obvious abnormality? And it's going to be an MCQ poll. So have a look at it. Remember, I said last time that you comment on the obvious abnormality. If there's something really obvious going on, then you might say right at the beginning, and then you might go back to interpreting it. So let's just click on here. Okay. So Here's poll 1. So have a go. And remember, it's anonymous, so it doesn't matter if you are not sure. Just have a go. And then I'm going to put the ECG up again, and we'll go into poll 2. So we've got 67%. I think we're going to stop at 75% in the interest of time. So we'll try and get to 75% of you having a go. Great. So we're going to end polling there, and I'm going to share the results with you. So I'm pleased to say that absolutely right. The obvious abnormality is the widespread ST elevation. So let's go back and have another look at the ECG. So here it is again. So you can see widespread ST elevation for sure. That's the kind of most obvious thing. Now the next poll is to comment on the axis. So I want you to comment on the axis and have a look at leads 1, 2, and 3 and think to yourself, is it normal, is it leftward, or is it rightward? So you've had a good chance to have a look at the axis. I know people find axis difficult, but I'm going to put the next poll up and have a go. So a couple more seconds. Okay, great. So we're going to end polling there, and I'm going to share those results with you. So you can see that 66% of you were right. It is a normal axis because although it looks almost negative in 2, it's actually still positive. So it's overall positive in 2, so it's positive in 1 and 2. So that is a normal axis. It's a normal axis. So what I would like you to think about now is to write down all the things that you can see on this ECG. So think about the RRP, WQST, and then have a go at writing down the report. I'm going to put my report up. My final poll, which we haven't managed to do because it has to be, we can't do a single answer. So just have a think about what you would call this as a diagnosis. So what would this be as a diagnosis? That's going to be another question. So I'm going to put my report up now. I hope you've all had enough time to think about that. So this is the report. It was sinus rhythm because there was a P and a QRS after each complex. So there was QRS complex after each P. It was a normal axis. The QRS width was normal. There are some Q waves. There are some raised ST segments, and correspondingly, there are some inverted T waves. So in a man who is 50 who has chest pain, it's an acute ST elevation MI. Okay, so on to the next ECG. So all of these are real cases, by the way, and real ECGs. So an 80-year-old woman, so this is my sort of patient I see all the time. She was referred to the syncope clinic. She had dizziness and pre-syncope, so she felt faint and she was breathless on walking. So in the poll, we're not going to do a single answer, but I would like you to think about what the rhythm is. And if anyone is brave enough, you could write that rhythm. So have a look now, have a think about what that rhythm looks like. I know we don't have a rhythm strip, so you don't always get a rhythm strip. Some of these are quite old ECGs, but you can see, because these ECGs without the rhythm strip go across. So you can see the rhythm. So have a go at writing in the chat if you fancy it, what you think the rhythm is. And then also have a think about the whole report. So have we got anyone in the chat? Okay, so Is everyone ready for me to move on? It is quite difficult to do this with 100 odd people, 152, which is a great number. So I'm just going to tell you, when you first look at this, you think it looks horrible, right? It looks like a horrible ECG. And it's a bit panicky because it's very difficult to see P waves. But do you remember I said that you can't always see P waves in every lead? So this is a bit of a tricky one, but this is the whole point of doing this kind of thing. So you have to have a look really carefully. Now, we also said that lead 2 was good for for looking at P waves. And you can see my cursor there and there. But also, if you look at V6, you can definitely see a P wave here, P wave here, P wave here. So let me just, so it's a good try VF. It's definitely not VF. I know it looks horrible, but it's not VF. So let's go on to the report. Whoops. Okay, so it's sinus rhythm because there is a P, Q, R, and S. The QRS is bigger. I'm going to come back to the ECG in a minute. There is a right bundle branch block pattern. So do you remember we talked about marrow? So you get an M, look, and you get a W in V6, so an M in V1 and a W in V6. And so this means that there's bifascicular block. Okay. So this is her, the same lady, admitted to hospital on a cardiac monitor. So what does anyone think of this rhythm? It's the same lady who was pre-syncopal. So have a look now at what's going on. It definitely does not look normal. So let me just look at the chat, make sure you've all had a chance. Yep, well done, Martha. Absolutely, it is complete heart block. Yes, well done. So lots of you saying complete heart block. So that's really good. Well done. So what you're looking at here is multiple P waves, occasional ventricular rhythms, which is a ventricular escape rhythm. So this is absolutely complete heart block. So what would you want to do for this lady? So there she is sitting in hospital. What are you going to do for her? Yeah, excellent, excellent. Pacing, pacing, pacing. Yeah, brilliant. Well done, everyone. So that's great. Okay. Check the patient and do some obs. Obviously, go and see the patient. Make sure they don't have a blood pressure of about 30. Okay. So this is complete heart block. Okay, next one. So another 50-year-old man. He is asymptomatic, but he's come to the hypertension clinic to have his to have a checkup. He's been hypertensive for 14 years, but he's not on any medication. And his blood pressure has actually been pretty well controlled for the last 6 months because he's lost a bit of weight, he stopped smoking, and so he's taken up a bit of exercise and his blood pressure's come down. So he's really pleased about it. So ECG4, let me just check my polls. So first of all, I'm going to ask you about the T waves. So the poll coming up is about the T waves. So we're going to do the full report normally, but have a look at the T waves. And the question is, are the T waves normal or abnormal? So we need okay. Making sure we've got the right polls for the right job. So are the T waves normal or abnormal? And then the next question is one of those questions that medical students dread really. What is the next step of management? So the next step is really being pedantic about what will you actually do there, here and there. Now, I think they're very difficult, some of these questions, because the reality is you do loads of them, but what are you actually going to do in clinic right there and then? And a lot of the time, the questions that you get in this sort of short best answer or single best answer questions, it's all to do with the STEM. So what is the next step of management does not mean, you know, yes, okay, you might want to do an echo, but actually it's thinking about what are you going to do now? Maybe you're not going to do anything. So I'll just give you another few seconds. Okay, great. So we've got 75% of you have voted. So I'm going to end the polling there. And we'll share that result. So the T waves are definitely abnormal. I hope you can see this with the polls up. I can still see the ECG, so I hope you can see that too. But the T waves are abnormal. So it's not normal to have a T wave in AVL or in 1. So these are abnormal T waves. So the fact is this man has got something wrong with his heart. And we've looked at these things. So he's hypertensive. He has evidence of change on his ECG. And if you look at his axis, so if you look at the axis here, he's got a positive 1 in 1, but definitely a negative in 2 and definitely negative in 3. So they are leaving each other. So he has a leftward axis and he has some T wave changes which are in concordant leads. So there's definitely some evidence of structural change going on. So he has problems with his electrical conduction. So he probably has some fibrosis. So the next thing you actually want to do is actually get him on ACE inhibitors to get his blood pressure lower. Now, I didn't give you the absolute, I didn't give you the exact blood pressure, but you don't want to do nothing. That would not be correct because we now know he's got something wrong with his ECG. That means he definitely needs an echo because we actually want to look structurally. Has he had silent MI? Has he got structural changes that would be that would need different treatments? With the outpatient exercise tolerance test, he's asymptomatic. So you would definitely want to check that he really was asymptomatic and really be clear that when he's exercising, he doesn't get any symptoms at all. If he's asymptomatic, you wouldn't bother. And you would certainly check his cardiac risk factors. So this is a bit of a mean question, but the evidence shows that if you've got end organ damage with hypertension, and he's had hypertension for a long time, so the fact is he's likely to become hypertensive again. And I didn't give you the numbers, so I apologize for that. Should have done looking back at it. But you really want to bring his blood pressure down to a decent level. So you would start him on ACE inhibitors. So just going back to the ECG, let's turn that off. So we've done that and we've looked at that. So this is the report. So sinus rhythm, normal PR, we talked about the left axis deviation and we talked about those T wave inversions. So he's likely to have had changes due to his hypertension over the years. And we don't really know with that T wave inversion, we don't know if it is ischemia. So we would definitely check his history, or it might reflect LV hypertrophy. And of course, the echo will show us that. I'm just going to go and draw my curtains because you can see I'm being dazzled. Okay, sorry about that. Right, next one. Let me just check if there's any burning. No, it doesn't look like there are. Okay, we've done that one too. Right, here's another classic ECG. 52-year-old. I think I've put a lot of 52-year-olds in. He could be 46. He could be any age. She could be any age. But it's a 52-year-old. Central crushing chest pain. They look really unwell. So, what's the diagnosis? Put it in the chat. We will, you know, again, this is one of those pattern recognition things. But if you're not sure, then go back to your RRP because you can still absolutely do it. And I'll talk you through it, but I just want to see what everyone is saying. So MI, pericarditis, tachycardia, yes. STEMI, tombstoning, thank you, Joe. Tombstoning, absolutely. So we talked about this before. So let's go through it from a sort of RRP. So the rate, you know, it is certainly pretty fast, and it's about 2.5 large squares, isn't it? So he's definitely tachycardic. Can you see any P waves? So yes, you can see P waves. So RRP, the axis is normal, and then just I haven't got any other polls coming up on this one. No, I haven't. So the QRS is actually normal. It's the ST. So it can sometimes make the QRS complex, make it seem like the whole thing is wide, but it's actually not. So it's the ST segment that is massive. And I talked a little bit about this in pattern recognition in the last talk I did, but this is massive tombstoning. So this is classic tombstoning, indicating an MI. So he needs, we've done that one. So normal axis, probably normal QRS, gross elevation of the ST segments and depressed segments in the inferior leads. So this chap needs to go for PCI. So you'd refer, if you were in Cambridge, you'd refer urgently to Papworth. Okay, right, here's another one, ECG 6. So this is a slightly older person, 68-year-old, so more breathless on exertion and then some exertional chest pain. So try and be really pedantic about your reporting. And the first poll coming up is a tick box poll, just step I'm right. So is the rhythm regular or irregular? And again, this is the sort of ECG that pans across. So we don't have a dedicated rhythm strip, but I just want you to tick whether it's regular or irregular. So let's go to that poll. So this should be here. Excellent. So quick one, is it regular or irregular? Brilliant. So most of you are pretty confident. And you're absolutely right. So that's great. So that's a great start. So it is indeed irregular. And then I want you to look about whether the QRS complex, whether you think the QRS complex is normal or abnormal. So let's just launch that poll. Here we go. So QRS complex, is it normal or abnormal? So you remember when we were looking at the tombstoning ECG, I said it can be confusing because when the ST segment looks so weird, I've given you a bit of a hint there. So the ST segment looks so weird, it can make you think that the QRS complex is abnormal. So you have to look carefully and think, what is the definition of a normal QRS? So the QRS complex should be 3 small squares or less. So lots of you have voted. So you're about split here. You can see that your colleagues are about split. So it is actually normal. It is a normal QRS. So you can see that it's definitely not wide. The main issue is the ST segments. So the rate is tachycardic again, isn't it? But because it's irregular, it can be difficult to comment on the rate exactly, but you can see it's going to be pretty fast at times. The rhythm we've said is irregular. Then we've commented, so we can see P waves. The width of the QRS is actually normal. Okay, the width is normal. Looking at the axis, it's all positive, so it's normal. And then if you look at the ST segments, this is horizontal ST depression. So there's no question this is ischemic. And then it starts to get more sloping, so sort of much more sloping down. And that, you wonder if he might have been, that could be a sort of reverse tick, a sort of effective digoxin. So let's go to the report. Done that one. Okay, we've done that one. Right, so it's atrial fibrillation. There is a normal axis. As we said, the QRS is normal. It's 3 small squares or less. There was very much horizontal sloping of that ST segment in lead B2, and then downward sloping elsewhere. And then there were inverted T waves in various places. So this is going to be severe ischemia. And as I said, when it's downward sloping, that kind of reverse tick phenomenon, that can be digoxin therapy. And we think that's probably quite likely if he's on, if he's got atrial fibrillation. And then the other thing to say is he's not going so fast that that's going to cause that degree of ischemia. So there's probably something else going on in terms of atherosclerotic change. Okay, let me just quickly check in with the chat. So please, hold on, let me have a look at these. It's difficult to do the talking and things. It's not regard. How do you differentiate between a big MI and pericarditis? Well, you'd look at the patient for a first start. can you please explain the second beat on leads 1 and 2? Okay, we'll go back. Does the height or amplitude of the QRS come into the decision making for how normal the QRS is? So when I'm really talking about the QRS, I'm really talking about the width. So you could absolutely say that yes, it becomes abnormal in hypertrophy. So yes, that's fair enough. That is absolutely fair enough. Okay, so let's just go back. So I think these are going to be sort of fluttery P waves. They're not, because it's too irregular, and you're not getting a regular P and then QRS. So it's still AF. What did someone say? What about, oh, this was what you wanted to know about in leads 1 and 2. So this is an ectopic beat. So it doesn't look like any of the other beats. So this is a ventricular ectopic because it looks wider. Can you see that QRS looks wider? So that's an ectopic. Okay, let's have a quick check in at the time. So we're half past. Okay, so let's go on to ECG 7. Okay, this is one of you a long time ago. This is a 20-year-old medical student who is concerned about having nocturnal palpitations, and they have a completely normal heart on examination. So have a look at that ECG and go through logically thinking about RRP, WQST, and we'll put a poll up in a minute, and I want you, the poll is going to say, is this ECG normal or abnormal? So have a good look. Okay, so I'm going to put the poll up. Okay, off you go. Is it normal or abnormal? And if you think it's abnormal, then I'd like you to think about why, because if I was with you on a ward round or you were with me in clinic, I'd want to know why. And if you think it's normal, I'd like to know why. So I'm not going to ask you all because there's far too many of you, but I would be asking you if you were in clinic with me. So 80% of you have said that it's abnormal, and 20% of you have gone for it being normal. And the fact is, you could argue it kind of both ways, really. So it was a bit of a silly question, but I wanted you to really think about the context. So in a 20-year-old medical student who's having nocturnal palpitations, let me just check in with the chat here. Normal ectopics, yes. So is there an ectopic beat, but otherwise okay? The palpitations make it worrisome. Okay, so well done everyone who's identified those ectopics, and I led that into you from ECG 6 because there was an ectopic there. So let's look at it. So there's normal rhythm, normal rhythm, normal rhythm, normal rhythm. There's definitely a P wave there. It's quite hard to see some of the P waves, but clearly a P wave here. So there are some ectopics, but of course, actually, it is normal to have ectopic beats. And so from this ECG alone, if the heart was normal, so there weren't any, the apex beat wasn't displaced, and there were no murmurs, then in a 20-year-old medical student, this is highly likely to be completely normal. If they were having a lot of palpitations, you might, but not necessarily would be indicated, but you might do a 24-hour ECG just to look at the amount of burden of ventricular ectopics. And if there are not that many, so maybe 1%, you wouldn't get very worried. If it's more than about 4 or 5%, you might get much more worried. But people who are thin, when they're lying in bed at night, particularly lying on their left side, are very sensitive to feeling ectopic beats, and it's normal. So everyone is allowed to have a few ectopics. If they were happening all the time, it would be more worrying. So if they weren't having them all the time, it wasn't bothering them particularly, they weren't having them during exercise, obviously you have to go and take a really good history. Okay. So we've done that one, and so just to report it properly, we'd say it was sinus rhythm, normal access, normal QRS complexes and T waves. So that's really, really important. There's no other abnormalities. So then we interpret it. So as I've already talked about, you could consider a 24-hour ECG, but you also want to then give practical advice. So are they drinking loads of Diet Coke? Are they doing any recreational drugs? Are they drinking too much coffee? And actually simple advice like limiting the amount of coffee they drink might be very helpful. And also the other thing is at nighttime, explaining to people that if you lie on your left side, you're more likely to feel them, and if you lie on your right side, you're not. And sometimes people just get very worried. Okay. What would you do if it was more problematic? So good question. If it's having a lot of ectopics, you'd want to think about why. So then you'd almost certainly do an echo to make sure the heart was structurally normal, because it would make you think, actually, is there something funny going on here? In a young person, I personally would obviously refer on to cardiology for this, but in an older person, if they had an echo that was, maybe showed a bit of regional wall motion abnormalities, so explained why they were having occasional ectopics, you might just give them beta blockers to make sure that the heart didn't get too fast, and sometimes it can help symptomatically, but you would try lifestyle measures first. So you would definitely make sure they weren't ingesting anything that could make things worse. Okay, right. Next one. This is another young person. So 28-year-old man, he's fit and he trains a lot, and he wanted to have a routine ECG. So this is his routine ECG. So have a good look at it. Think about your logical approach. I remind myself of what poll is coming up. Okay, so it's going to be an MCQ poll, and there's going to be a multiple choice on what is the abnormality. So just have a look at it now and think rate, rhythm, P waves, width of QRS, ST segments, T waves. So is there any abnormality or not? So let's put the poll up. Here we go. So it's really, I always think ECGs are a bit like looking on a cereal packet for spot the difference. You're just, every time you're trying to look at what has happened to this ECG, and then you're putting it into the clinical context. So I think maybe this one people are finding a little bit harder. Less of you replying, or maybe you're just bored. Difficult to know when I'm sitting on my own here with no one talking to me. Much easier in a classroom when I can see whether you're engaged or not. I'm hoping you're engaged. So a few more minutes, a few more seconds even to get up to 75% of you. Brilliant. So we've got 75%. Well done, everyone. So let's share the results. And well done to those who said, so deep, so let's go through them. So deep S waves, there are very deep S waves, but it's not really specific to anything much. So I wouldn't get too excited about it, funnily enough. It's not typical for hypertrophy. And then the T wave inversion in AVR is normal, so that's not correct. So in AVL, there is definitely a sort of flattish T wave, but it's a bit, non-specific really. And there is indeed right axis deviation. So 1 and 3 are reaching towards each other. So then the next question, and I'm just checking if I've got a poll on this, which I haven't. So the next thing to think about is right axis deviation always abnormal? So have a think about that. We haven't got a poll on that one, but have a think about what you would say to that question. Is right axis deviation always abnormal, yes or no? So let's go on to the report. So the QRS complexes, as I said, they're sort of, yes, they did seem quite big, but they weren't typical of anything. So it would be sort of non-specific. The T waves were normal because that AVL is just not that exciting. And so actually, if the patient is tall and thin, which this chap was, then it would be normal. Okay. And then you would think about right ventricular hypertrophy, but there weren't other features of those. So you'd be looking for tall R waves in V1 and also T wave inversion. Okay, let me just check again. No, it depends on habitus of the patient. Well done, Joanna. Very good. Excellent. Right. Okay, let's check how we're doing for time. Good. Okay, so we're going to go on to ECG 9. 73-year-old man, severely breathless, blood pressure around 90 systolic. He looks really unwell. So if you're not sure, go back to your basics. Think about your rate, your rhythm. Try and find some P waves. Think about the width of your QRS. Look at the ST segments if you can. So have a good look, have a think. Okay. So I'm going to put a poll up. And this poll, while you're still looking at it, is asking you if the QRS looks normal or abnormal. Okay, brilliant. Well done, everyone. So that's fab. So it is absolutely abnormal, isn't it? It's wide. This is an alarming ECG. This is a call for help immediately style ECG. Okay. I just haven't got any other polls coming up on that one. No, I haven't. Okay. So have you written down, I hope you've all thought about what you think the diagnosis is. So it's a broad complex tachycardia. That's the first thing to say. So this goes back to, you know, just thinking about your resuscitation sort of approach, really. So, you know, you just describe it as you see it. All you need to know is this is a broad complex tachycardia. So this is very bad. There's no P waves at all. The QRS complex is wide. I wouldn't worry about the axis on this sort of ECG because it can be really hard to see when it's all over the place. So this is likely to be VT. And he does still have a blood pressure, so that's good, but he is absolutely sort of peri-arrest, really, and he's likely to be DC cardioverted if he doesn't go into arrest pretty soon. So this sort of ECG is absolutely worrying, and you need to call for help immediately. And you would call for you'd probably just phone 222 or whatever your, you know, nationally, of course, you'd back up for, you'd phone for help or get the resus team right there because something's going to go wrong pretty quickly. Okay, I think we have one more. ECG 10. Okay, this is a classic ECG. I saved this, the best till last. So 70-year-old, dizzy, another one who's had hypertension, but to be honest, lots of 70-year-olds have hypertension in their past medical history. Pulse is distinctly irregular on examination. Blood pressure is normal. So have a good look at this ECG. This is a hard ECG. So the last poll we have is asking, can you see a normal sinus beat on this ECG? So by that, I mean a P followed by a QRS, but with a normal PR interval. So do you think there are any normal sinus beats, normal in every possible sense. So let's just get the last poll up. Okay. Let's end that and share that. So you're pretty much split. So I think there is a normal one somewhere. Whoops, that's happened. So I think one of these early ones is within 5. I think there's a normal one here. I think these first few are normal. That one doesn't look, that one I think is normal. So the PR, maximum PR interval is up to 5 small squares. So if we go through this ECG is really interesting. So there's lots and lots of different rhythms. Does anyone want to put on the chat what rhythms they can see? So we're really looking just at this rhythm strip. So if we said this was normal, and then suddenly this is becoming less normal, and then this is becoming less normal. Let's see what you're all saying. Maybe a winky back, yes, absolutely. And then a bit of 2-to-1 block. Yeah, so it's really fun because there's lots and lots of things going on. Well done. So let's just talk through it. So you've got sinus rhythm, and then if you look, you've got a lengthening PR interval. Okay, so there's the lengthening PR, really long. Then it gets dropped. So that's a dropped beat here. And then, so that is definitely not conducted. So that's 2-to-1. And then here, rather than it being winky back here, this is actually 1st degree heart block because you've got the same PR interval here as you have here. So you've got a bit of sinus, then you've got a lengthening PR, then you have an actual, so you have, there's a lengthening one, but then you have a QRS and a missed one, a QRS and a missed one, so that's 2-to-1 block. And then you actually just get sinus, but with a long PR interval. So he's all over the place. So that's quite an amazing ECG, really. So we've done that. So first 9 beats show sinus. This is the report. So you'd talk through it, you'd talk about the rate, and then you can talk specifically about the PR interval. So the PR interval slowly increases. Then you get a non-conducted wave, and then you get a conducted one. And then, and again, we've talked about those bits, but then you'd also say, because you'd finish up your report, a normal access and normal QRS complexes, ST segments, and T waves. So what would you like to do for this man clinically? Pace him. Yeah, you're going to pace him. You're absolutely going to pace this person. So you know, they're not actually syncopal yet. They haven't had syncope, but 100% they're going to go into complete heart block. So once someone's you know, having multiple different blocks, they will go into complete heart block soon enough. So you want to admit this person, and you would want to pace them urgently. So sometimes you might see someone who had a fall a few weeks ago and they were in bifascicular block, and you'd think, I reckon they're going to need pacing, and you might pace them electively. So you might wait a few weeks and then put a pacemaker in, or you do it non-urgently. But someone like this who's got this degree of irregularity, you are absolutely going to admit and you're going to pace. And that, I think, is the end of all my ECGs. That's 10, and I think we've done it before 7 o'clock, so we've done pretty well. Any questions, anyone? I hope that's been useful. Hi, Ben.
Great, thank you so much, Dr. Hampton, for doing that. Any questions, please do feel free to unmute yourself or post in the chat if you've got any questions.
Okay.
So quite a few people have been asking about the recording. That's going to be posted at a later date, and we'll look out for details of that on our Facebook page. Any other questions on the chat? The feedback's going to be posted in the chat in a minute. Please do fill out the feedback. It's really helpful for us to know what we can do to help in the series, and Dr. Hampton, I'm sure, will welcome any feedback as well. I'm just checking in the chat now to see if there's any questions which have come up. No.
So what I would just say is, could I explain bifascicular block? So bifascicular block is where you have to think about the little diagram of the electricity going through the heart. But if you have a right bundle or a left bundle branch block and you have axis deviation, then you always have to go back to that diagram. I wish I had a picture of it, but you have to think about where you've got your SA node going down to your AV node, and then you've got your right ventricular go down your bundle of His, and then it splits, and then you've got your left bundle which splits into two, and you can think about where all the blocks are and how many you've crossed off. So you've got bifascicular and trifascicular. Now in old people who have had a syncopal event or an unexplained fall, then you would actually want to pace them for bifascicular block. In someone who's completely asymptomatic with bifascicular block, you wouldn't necessarily pace them at all, and for trifascicular block, again, you would absolutely pace someone, but it all really depends on symptoms. So I would absolutely urge you all to get into the habit of reporting an ECG and then interpreting it in light of the clinical situation in front of you. And obviously for exams, you're likely to have a patient actor in front of you and an ECG. So you'd always say to the examiner, please may I have a blood pressure on the patient, because then it shows you're thinking about the patient. But the other thing is that, we've only covered 10 ECGs. Just look at ECGs on every patient that you see, and just get into the habit. If you're bored on a ward round, I mean, a lot of the feedback we get from medical students is that ward rounds can be really boring and you don't know what to do and you feel like a spare part. So I have to say, Ben, who's hosting this, Ben was a brilliant year 6 because he really did everything that a house officer was doing. So I would urge you to try and step up if you can. That's a completely different talk. But just generally, make the most of your ward rounds. And if you're bored on a ward round and you don't think you're learning very much, just start looking at the ECGs on every patient. Fold the top over so that you're not being, otherwise your brain becomes biased by the printout at the top. Fold it over, and then just start by going through the ECG in your head every single time. Approach it the same way, and then look at the patient and think, what did they come in with? Has this ECG just been done because they're in the hospital? Is it relevant to the clinical situation? And interpret it in light of the clinical situation. So practice, practice, practice. My computer crashed when is RAD normal? So tall, thin people. Any chance of going over ECG2 again? Always find Q waves difficult to spot. Okay, should we just see if we can do that? Can I just, if I stop the share and then I restart a share, it'll be easier to go back to 2. Okay, so here's ECG2, and let's just make it big again. Oh, that's very annoying. I'm sorry. There we go. ECG2. Okay, so the Q waves, the thing about Q waves, they can be hard to spot, and of course some can be normal. So you've got a Q wave in 2, you've got it in 3, and you've got it in AVF. So they are all in the right, so they're inferior, and they are bigger than a couple of millimeters, and the fact that they're next to each other makes them much more likely to be significant. Does that make sense? So they should be broader than 1 millimeter, and they should be deeper than 2. So you can see they are deeper than 2. And then if they don't meet that, but they're in leads that make sense anatomically, then that's why it's important. Thank you so much, been really helpful. Thank you very much. Thank you very much. Good. I think we're done then.
Great. Thank you very much, everybody. Our next session will be on the 17th. We've got a couple of weeks off, so 17th of May. Please look out on our Facebook page for more events. And I'm going to hand over now to Rory from UEA MedSoc.